All right. Well, good morning, everyone. My name is Dr. Jennifer Mills Price. I'm a psychologist, and I work for the Joan C. Edwards School of Medicine down here in Huntington in the Department of Family and Community Health. I've been with Marshall for going on 8 years now, and family and community health has been my academic home for almost 5 of those years. So time does fly. And I'm going to be talking today about how we can pay attention to and help enrich the well-being of children in care. I'm going to be using that term as a broad term to refer to both foster care and kinship care placements. But when I need to differentiate between the two, I will try to be clear on that. All right. So I went through most of that. As far as any disclosures, I'm not being paid by a drug company or anyone else like that to say anything in particular today, but I am employed by the state. And there are parts of my role that are funded by research. Also, my program that does wraparound services for women with substance use disorder who are pregnant or parenting, we do receive additional funding outside of Marshall to pay for those services. All right. Why do I have opinions and hopefully educated opinions about kids who are in care? Prior to coming to Marshall for the first 7 or so years of my career, I did primarily forensic work for Hudson Forensic Psychology in Charleston, West Virginia. A lot of my time was working with kids who were involved in the child welfare system. So I did a lot of court ordered abuse and neglect assessments, the psychological portion of CAPS assessments, assessed a lot of status offenders, truancy, juvenile cases, and then also assessments to place children who were in need of residential placement. And then since I've been at Marshall, I'm focusing mostly on clinical interventions. My program is a wraparound program for women with substance use disorder who are parenting. Mostly that's with the littler kids, but we are seeing an increase in families being reunified with older children after there's been some level of termination or relinquishment of their rights. Not very frequently, but I've seen a couple of cases where those are under consideration, and we provide support to those mamas as well, even though their kids are older, usually around the age of 12. We also serve families who are unhoused, regardless of the age of their children, young adults, regardless of the age of their children. And in my work here at clinics, some of the patients that I see, we have a large portion of our general outpatient clinic are adult children of alcoholics and dysfunctional families. So I see a lot of people who experienced maltreatment or lived in foster care when they were kids, and I see them as adults. So I have a lot of different perspectives from which I've seen this issue, and I hope you all will forgive me for anything that I may say today. And I will disclaim that I'm talking about people. And so there's always differences inherently when you're talking about people. So research is based on large groups of people. And that means that there's going to be individual variation based on, cases that you might have experienced or even personal experiences that you might have. And also, I'm going to be talking about different systems and how they work together. I'm part of a system. I'm in the healthcare system. I used to be more attached to the legal system. And so sometimes our perspective's different in that way. And I hope that we can all share and everybody feels comfortable to correct me if needed. In addition, I'm going to be talking about programs that have publicly available information. And so if there are newer things that people on the call are doing that are not included in today's version of the presentation, I would love to hear about them, and we'll kind of save that for the end. All right, so our learning objectives are to analyze West Virginia foster care trends from 2019 to 2024. That's where we've had the most action, I'd say. To be able to identify some trauma-informed best practices that improve outcomes for kids in care. And also, at the end, if we have time, I do have some case vignettes, just in case we didn't have one submitted, which we didn't have one submitted today. So if we have time, we will go through those as well. So what is our why? Why do we want to talk about this topic? West Virginia, unfortunately, for a small state, we have a disproportionately large number of kids who are in care. We peaked in April of 2020, wonder what was going on then, at around 7,400 kids who were in foster care at that time. And the lowest number that we have recently is in June of 2024, last summer. We had gotten under the 6,000 mark, which is huge for West Virginia. However, we are still among the nation's highest rates of out-of-home placement for children. So what we want to talk about today is what has changed for the better and what do we still need to work on. Okay. So over half of these kiddos who are in care are in kinship care, which is actually a positive thing that we have in West Virginia, that we have a large kinship network of families that are helping to step in to take care of these kids when needed. We've also seen some improvements in congregate care when kids are placed out of home in a group living situation. And by the end of 2024, that had reduced from about a quarter of the kids in care to only 14%, which is an improvement. We want these kids in homes to the best of the ability of the system to make that happen. We're also seeing lower entry into foster care. Although we are still proportionally one of the highest states, that is slowing. And part of what we think has been so helpful at moving those numbers is what the state has done to expand both kinship placement and to support kinship cares, and also workforce stabilization within child protective services and youth services in general. So what are some things that matter when we're looking at our kiddos? What are things that we want to pay attention to? All of these items that have the asterisk are things that West Virginia does have policies on. That is really important that we look at these things. However, the ones with asterisks, we don't have publicly available data on. So I'm just going to talk real briefly about those and then spend a little bit more time on the things that we do have data on. So we do have guidelines about having completion of medical and dental evaluation and catch-up visits for kids who have not had well child visits. A referral to early intervention is mandatory for kids who are in that time frame to at least get the evaluation from birth to 3. We measure whether a child who has an IEP is able to transfer that IEP. We measure sibling visitation. Also assess for mental health access, and some of the timelines that are involved with things like CAPS assessments help to make sure that that's a priority for us and that those kids are getting referred if there's a clinical need. We do measure, however, and publicly report on placement stability, which is the number of moves that a child has to make within a 12-month period. Some of you should probably know, I would think, that the number of moves is an independent predictor of poor outcomes for kids. So the number of times that they are moved after being taken out of the home, even if you control for other things like what their premorbid functioning was, whether they had a disability before the removal or not, the number of times they are moved predicts that they are going to have a hard time. So what we have seen is that in 2023, which I believe is the most recent numbers that we have, that kids had fewer than or equal to 2 placements within 12 months, which is not bad. So what that means, though, is that there is a portion of those kids, about a fifth, 21%, who did have 3 or more moves in that first year, which is concerning for us. Because the longer that a child stays in care, so in addition to the number of moves, the amount of time that they are out of their home predicts difficulties with stability. So they're going to have instability with school visitations, permanency, things of that nature. Okay, so that's those kiddos we need to keep an eye on, that 21%. And we also have publicly available data on permanency that is achieved within 12 to 24 months. And so what we've seen is that kids in care generally is down from its peak. We're approximately under 6,000. There is a dashboard where you can check, and more or less on a day-to-day basis, it's updated with how many children are currently in foster care. And I believe we're either hovering at or back under 6,000, with half of those kids being in kinship care and 14% being in congregate care, as we mentioned on the last slide, and those entries easing down. And I believe we are seeing improvement. I might have cut and pasted the wrong thing in there. We are seeing improvement in kids that achieve permanency within the 24-month period, so within a 2-year period. So I'm trying to see everybody and move this around when I need to talk. Okay. What are some things that we're doing very well? So we have very low incidence of maltreatment in foster care, among some of the lowest rates compared to other states in the country. Also, recurrence of maltreatment is improving. So, families that come back to the notice of CPS for another incidence of maltreatment after there's already been an investigation and a case open, those are going down. And it's better than prior years and lower than many other states, which is always good news for us when we're doing better than someone other than, just us in Mississippi duking it out at the bottom. And time to adoption is improving. So we had a rise in children who are adopted within that 24-month period, rising to 60%, so more than half.
Hey Jennifer, there was a question in the chat that says, what is congregate care in the context of the last slide where permanency is mentioned?
Yes, so congregate care, that one, it seemed like I just maybe organized it incorrectly. So it's not necessarily the children who were in congregate care were achieving permanency at different rates. Congregate care just refers to group placement. So that might be like a children's shelter or a group home. Does that make sense? Okay. And any follow-ups, if that wasn't clear, I can try to do my best. All right. Other things that we are doing well, as I mentioned before, having so many children as we do who have to be placed outside of the home, having them in family placement is really important. And really at that last benchmark of the 5,991, that is the lowest number of children that we have had in the state's custody in 7 years when we achieved that. It's bumped up a little bit, but I think, like I said, I think it's right at or not much higher than 6,000. So we've maintained a lot of that progress. And we are high utilizers of kinship, which really, I'm from here. My dad's side of the family lived in Mercer County since before it was West Virginia, when it was still Virginia. So I think we all know culturally we look after our own. Family is very important to us. And so when it is an option, we will step in and do for kids in our family. So permanency being able to be achieved if a child is out of the home for what we would consider a longer stay. So they've already been out of home for a year or longer. We actually are able to achieve permanency for them at higher rates than other states. A lot of times those kids can end up in a situation that we used to call foster care drift, where they were not able to achieve permanency and would end up drifting from placement to placement until they eventually aged out of the system. And we are actually able to find permanency placements for those kiddos in our state compared to some other states. And also, even though this is not directly a metric that we necessarily measure with foster care together, a lot of the utilizers of this service will be not enter the foster care system. However, something really great that's come about in the last several years is the 24/7 Children's Mobile Crisis Unit, or the call line, which is with the Help for West Virginia. And there's been a lot of utilizers of that. It's over 100 calls per month. And we are hoping that that is helping prevent some situations where kids would ordinarily be taken out of the home. We're hoping to prevent that by being able to come up with a game plan for families and to address their children's mental health crises. All right, when I'm referring to well-being, what do I mean? Because we all mean different things. So I'm referring to, in general, 3 types of things. So the physical side of well-being, the children's physical condition, their teeth, their speech and communication, their learning and behavioral health conditions. And these are things that can be within normal limits. They can be things that were issues prior to whatever psychosocial crisis led to the maltreatment. So these may be things that are incidental to whatever the parents were doing that was concluded to be maltreatment. It can be genetic. But these are all things that it's important when the children are in our care, they're in the state's care, that we need to make sure that those are all functioning properly and the child's getting appropriately screened and sent in the right direction for treatment if it's needed. Well-being is a sense of stability. So as I mentioned, we're talking about people. People are all different. Kids are all different. And kids who are in different developmental stages are going to have slightly different needs. And also the conditions that our kids are coming to care with are all so different from one another. So I think for all of us that work with families that have been affected by substance use disorder, we see the whole variety where sometimes there are early attachment issues if the parents were not able to be part of the child's life very early on in that postnatal period where typically attachment is going on. Sometimes that part of the child's life will actually be relatively incident free, and there's something that comes about later. And so kids may be the same age chronologically, but they may be coming to care with completely different attachment styles, and they may not be all ready for the same thing. They may not respond to the same things differently. But one thing that they really need is some sense of stability because they need to feel that they have some level of being able to predict and control their environment in order to achieve other developmental milestones that they would be expected to achieve. So we want for their school, their living environment to be safe, predictable, and we also want it to be affirming. We don't want kids to feel like they're an unwanted guest in somebody else's home. And well-being is also highly contextual. So you may have two environments that are both equally habitable. They have all the basic necessities, but what is in the child's best interest is going to be very context dependent. So are we looking at setting up a plan where we know reunification is on the table from the beginning? Because that might make some differences in what choices we make for that child. So we definitely, when we're considering well-being, we want to look at long term, how is our plans for this child going to fit into their story of their life? We can't predict everything, but we can at least take it into consideration. So how do we know if we are doing that correctly or not? So on the physical side, if kids are receiving timely, appropriate healthcare assessments and interventions, and their records travel with them. So home two knows what just happened in home one, or at least the worker is aware of all of the differences that have occurred, so we know what kinds of issues we are tracking and what if there's been an appointment that was scheduled but then placement changes, how do we make sure this child still gets their specialty appointment or they get the equivalent what is in their area. Stability is going to be different for different families and what's appropriate, what's safe. However, they might stay in the same school. They might be able to stay in the same home as their siblings or with half siblings. Might be able to stay with family. And regardless of how the parents are doing with any kind of improvement period, we would want to see that any appropriate family or even fictive kin, whether that's a teacher, a coach, anyone who has a special interest in this child and is appropriate, we want to make sure that they continue to have that contact, particularly if their home environment can't be the same all the time. We want to make sure they're still invited to birthday parties and get to talk to grandma and grandpa and things like that. It's not the child's fault that they might have to be moved. And in terms of context, how do we know if we're doing a good job with context? Is it, again, kids are in care, they're going to be different ages, different intellectual levels, different ability to understand, and some things aren't going to be appropriate to tell every single child, but we want them to have some kind of developmentally appropriate, reasonable understanding of what's going on, how long it's going to take, where they're going to go, etc. All right. So, what are some things that we do already have? So, as I said, we already have timelines for these. So, in West Virginia, this is something that we are prioritizing. So, kids who enter care, and please, if any of this is way too basic, if these are things everyone knows a lot about already, you can unmute yourself and maybe gently tell me to hurry up a little bit. But anyway, so once a child enters foster care, they're in the state's custody, they are going to get caught up on any of their well child vaccines and testing screening that they should get for their age, um, and dental vision checks. And we really want to make sure that their sleep and their basic nutrition is adequate. Kids who have experienced a lot of neglect, which is not every child that enters care, but it is some of them. It's a substantial part of the population. They may need some specialty intervention around getting adequate sleep and getting adequate nutrition. They may be used to very limited diet, and we want to make sure they're eating healthy foods or getting used to different kinds of foods. Ideally, a child will have a medical home, so they'll have a primary care pediatrician, someone who has followed them over time. Some states have what they're referred to as a health passport. I believe the state of Texas has this for records across placements. So it's a separate electronic medical record system, you could call it, or something like FACTS, where it's a private database of information, so that people are able to access the child's records from previous placements. We don't quite have that, but Aetna does have something similar to that. And if something were to ever escalate to the point the foster care ombudsman would need to get involved, they do have access to all of the child's records. For little bitty kids, so neonates and first year postpartum, we see a lot of prenatal substance exposure in West Virginia. That's certainly the case in my catchment area in Huntington. We unfortunately still have a very high rate of intrauterine substance exposure, even though our rates of neonatal abstinence syndrome are going down, in part because of drug trends. Opioid use is just not as popular as it once was. Things that can help to protect the child's well-being. And a lot of these developments have happened really since I made that transition from private practice to Marshall Health. And that was one of the things that brought me to Marshall Health, was instead of remove first, ask questions later, which used to be the standard of care when someone was on buprenorphine or methadone during pregnancy. There are a lot of practices that are now becoming more commonplace to keep mom and baby together as long as it's safe and appropriate. Some of those things are rooming in at the hospital, eat, sleep, and console, getting the family referred to early intervention as soon as possible, referring to speech and language screening as soon as possible. Also, coaching caregivers on interacting with children. Something, again, if you're used to working with this population of foster care and respondent parents, you will know that a lot of them don't necessarily come from the best backgrounds oftentimes. And so they may not know what skills are going to help with encouraging things like bonding, encouraging early speech, and things of that nature. And so, if we can encourage that through home visitation programs, for example, that is a way of making sure that that baby has the best possible foundation for the brain development that it's going to need for the rest of its life. And to align with plans of safe care workflows where applicable. West Virginia we're a little bit of an oddball with our plans of safe care, where that is directly related to our CPS referrals. Anytime that a mom tests positive for a substance at delivery, so there's not really a good way to separate those out. But a lot of the drug-free moms and babies programs that I'm sure have been discussed in other sessions, that is a way of providing that plan of safe care regardless or in combination, alongside, however the CPS part of the case plan works out, the Drug Free Moms and Babies program can provide support to mom while she works through any other requirements that may be made of her by Child Protection Services. Okay. The important mental health screenings that are needed for kids in foster care are going to obviously be things like signs of trauma, depression. ADHD is a very prevalent in this population, in part just because it is a very common neurodevelopmental disorder. So if you're going to have a neurodevelopmental disorder, ADHD is the most likely one that someone would have, just base rate. But we also see it a lot in our families, and it is highly genetic as well. And if a child screens positive and we are selecting some kind of intervention or therapy for them, we want to prioritize evidence-based practices. West Virginia has really wonderful infrastructure for training on trauma-focused CBT. And then we are kind of working on building that workforce for parent-child interaction therapy as well. But those are both evidence-based practices that treat disruptive. The PCIT treats things like the disruptive behavior, kind of parenting concerns, oppositional defiant type behavior, dysregulated behaviors, and the TFCBT more directly targets trauma, symptoms of trauma. And they both involve a component of training the caregiver. Psychotropic stewardship is just a fancy way of saying we want to make sure we know what medications this child is on and why. We want to make sure they have their medications if they are switching placement, and that they're able to stay on medication that's working for them. We also want to make sure that these kids are not over medicated and that they are not continuing to be on medication indefinitely because they might have needed it at a prior time if it's no longer warranted. So that's what the stewardship aspect is just paying attention to medications that a kid is on and taking that seriously, but also keeping in mind that just because a child was on a medication in the past does not mean that that's going to be something that needs to be refilled and prescribed indefinitely. And in fact, I'm calling to mind a very specific family that I evaluated where the children appeared extremely disruptive while they were being neglected when they were in the family home. And one of the siblings in particular was in placement. He was able to have his medication adjusted, and he was the calmest, most polite kid. He had gained weight because he was finally eating. So we want to make sure that we not only that kids who need medication do get it, but kids that don't need to be on certain medications, that we explore that alternative as well. Similar to what some of the DFMB programs achieve in a less formalized way, like a lot of us have cobbled together these kinds of relationships with our court system. But what OSU is doing is they have this kind of three-part program. They refer to it as the EPIC framework, where the if there is a situation where there are the primary maltreatment is the parents utilizing substances, that the parents are able to participate in family treatment court, which we finally have one in Huntington now. So yay for us, we've joined the club. But parents in the EPIC framework are in the family treatment court. They also receive support from a peer support who has successfully gone through reunification. And the family member that has a kinship custody of the kids also receives help at the same time. So the whole family is being supported while these changes are going on. I just think that's great. This is also a similar concept as safe babies court teams. I'm not aware of any specifically safe babies court teams in West Virginia, but I know a lot of our family treatment courts do essentially operate in this manner where the peer support and the family treatment court are in very close contact. But safe babies, the only thing I would add to this when we were thinking about a safe babies court team is that they start talking about permanency from day one, because that early developmental period is so sensitive to set the child up for later outcomes, that they want to make sure that at every step, they're not waiting until the child is 6 months old to talk about permanency and backup plans. Be good coverage, I would say, except for Jackson County. So if anybody on the call is from Jackson County, if we can help advocate for you, like you need some kind of coverage for family support centers. Um, and then some counties like Cabell, Kanawha, and it looks like Broken, Ohio have two centers. Um, I'm I'm most familiar. I know we have more than one in Huntington, but I'm most used to working with the Children's Home Society. And what happens is if you have at-risk families, whether this is the respondent parents or this is grand families, or if this is a family that has been reunified but still is at risk because of socioeconomic factors and just really struggling, um, these can provide voluntary services that kind of kick in, either before or after CPS, so the family still has support. And that's one way West Virginia has invested in helping our kids. And some organizations I'm familiar with that offer family support to specialty populations, this would be a good thing when we get to time for Q&A, that if you're aware of other programs, please let me know because I might not be aware of them. But West Virginia State University oversees the Healthy Grand Families program, and they have an educational component. And this is specifically for, pardon me, for families, grand families that are not involved with CPS. So these families are a lot of times stepping in to prevent CPS from getting involved or to prevent a crisis from happening, but then they don't get the benefit of some of the resources that would be available if they had an open CPS case. So that is a challenge. And so Healthy Grand Families aims to stand in that gap and to provide education. And then after completing the educational series, you can receive essentially case management. So it's each region has its own social worker that can help connect that family to resources. And I think that's been really great. There's such a big, the big generation gaps between grandkids and school-aged kids or infants. And just knowing what's out there is hard even for us who work in the field full-time. I can't imagine being a grandparent and trying to navigate all that by myself. A newer organization, the West Virginia Foster Adoptive and Kinship Parents Network. The director is actually one of our first family navigators for Healthy Connections. So she's got a lot of training in trauma-informed and family-based services. But they are an advocacy organization for foster, adoptive, and kinship parents to be able to access resources and advocate on behalf of the kids who are in that type of care. All right. I'm mindful of giving us enough time to have some questions, so I might be a little quick at this point. So resilience, I would ask people to raise their hand, but I can only see a couple of us in the screens. We've all heard of resilience. And if you're as old as I am or older, it may have been like this that you learned about resilience, like a list of here are the 40 factors that are the resilience factors, and a child either has them or they don't. And that's frightening because what if you're one of the kids that does not have one of these 40 factors, right? So, what I'm proud to say, even though I didn't have anything to do with it, I'm just proud society is advancing. Now we think of resilience more like this, like there are resilience mechanisms or processes that are going on, but it's not just a list of things you either have or have not. So, emotional resilience, things like emotional regulation, being able to give yourself positive emotions, social connectedness, being able to physically recover from stressor. So self-care is an example of that as a resilience factor, and resilient thinking. So optimistic thinking, flexible thinking. For the therapists who are on the call, this sounds a lot like therapy. So these are things that can be taught as opposed to a list of things that a child either has or they don't have. And I think that's really a great sign of progress that we've made. So resilience is dynamic. Kids can look different in terms of their resiliency at different points in time. It's longitudinal, it develops over time, In fact, what makes resilience different from just having positive qualities in general is that it's in response to hardship. And so some of these characteristics are developed by going through hard things with appropriate support. Resilience is ultimately it's inclusive. So the more the more appropriate adults who care about a child, the better outcomes they're going to have. And I think we've all heard the quote that having at least one adult who is invested in that child's well-being might be all that it takes for a child to have an improvement in their outcomes. All right. These are some other things that are going on. Again, I want to be kind of quick when it gets to this part. This is very cool. Another project from OSU that's going on is where non-custodial fathers read a book alongside their child. So the child gets a copy of the same book that the father has a copy of, and then over the phone or FaceTime, they read along together. I think that is such a great way to connect, and it's actually something I've found myself recommending to folks that are going through a custody dispute, even if it has nothing to do with CPS or the child welfare system. But if there's one parent that's non-custodial and they want to form a meaningful connection with their child, I think it's such a great idea. Youth transition, the short part of it is that it is challenging. We do have financial investments from the state in helping these kids. Getting them access to what they're entitled to is often the challenge. And then if the child is in kinship, especially if there's never been a formal transfer of custody to the state, if this was preventative on behalf of the family, they're not eligible for a lot of those. But some of the things that they are eligible for, and I'll send these slides out to the team, so anybody who wants to kind of catch up on the tail end of this presentation can. But there are some services that even if children are in a kinship, like an informal kinship placement, they still are entitled to. We have in Huntington, we have an outreach office called the Center, and so any person in the community, they don't have to screen any sort of way but they have to be under the age of 25. These emerging adults can come in and learn what benefits they might be eligible for, and also just to help access the broader social safety net that we have. They may need housing, they may need a medical card, they may need all these other things. All right. So I will hand things back over to Chantry.